I'm Dr. Utsav Bansal, Ophthalmology faculty at Marrow, and this is a session on clinical vignettes. So, apart from being a fancy name with the word clinical in it, what is this session all about? So, this session is basically, essentially about using the theoretical knowledge that you have into a clinical scenario. So, this session does not give you any MCQs. I'm not teaching you any MCQs here. I'm essentially teaching you how I approach a patient in my OPD, right? A patient comes to me with a certain complaint. Then what are the questions I ask myself on how to treat the patient, on how to reach the diagnosis, on how to form a differential diagnosis? What are the clues that I look for in the patient? So basically, we are trying to tell you that clinical is not a word that you should be afraid from. Essentially, all of you are going to become clinicians, yes. So it is a paradox, yes, it is a juxtaposition that we are afraid of the next exam. And that is what essentially this session is about, yes, tackling the phobia of the next exam. In the next exam, we are again and again worried about how the paper will become clinical. And that is what we are trying to break the myth about. That whether it is NEET, whether it is next, the knowledge remains the same. It is just about using that knowledge. And that is what I will exemplate in this session. This session, I have divided into 3 parts. In the first part, we will be presenting some clinical scenarios and the variations of those clinical scenarios and how you go about them. Again, these are not MCQs, these are open-ended questions. The second session will have some viva voce questions, not the usual viva questions that you are asked, but certain questions which should be asked and which are even asked to students who are able to answer those basic questions. And then the third part of this session would involve a new type of MCQ, which is called extended matching MCQ, where you will realize that if the MCQ pattern changes into a more difficult pattern, but still it is clinical, how may it look like, right? So this is just a peek into how your teachings may be or how you need to study moving forward if and when next does come. As I always say to all my students, the best way to study is to teach. Yes, I have become a better student after I have started teaching. And similarly, the better way to become a clinician is to ask the question yourselves. Once you get into that format of asking the questions yourself, you think about the answers much more clearly. And that is what we are trying to do here, asking ourselves the question without the help of those 4 choices that we essentially always get and are used to, right? So let's start with our first case scenario. Our first case scenario is about the red eye. So redness of the eyes is a very common complaint by the patients, but it can have thousands of causes. It can have tens of different implications, diagnoses, and that's what we're going to tackle here, right? So let's read the question that is given to us. A 32-year-old male. So the first clue in every question has to be the age, right? Based on age, a young age or a child or a neonate or an old age, we are able to form a differential diagnosis. Comes to the OPD complaining of redness in both eyes. Redness in both eyes, that's the clue again. Both eyes have been affected since the past 3 days. So it's an acute presentation, right? Form a list of probable differential diagnosis. That's the first question. That's the part A, I can say. And then part B of this question is, what other questions would you like to ask the patient to proceed? Okay. So what is the other history you are trying to elicit from the patient to be able to narrow down on your options in the differential diagnosis? So 2-part question, I can say. So let's tackle the first part. Form a list of probable differential diagnosis. So basically we are asking you, what is the differential diagnosis of a red eye? Yes or no? So differential diagnosis of redness in eye. I would think this is pretty easy. Yes. Let's start from the outside into inside. So first of all, conjunctiva. The first thing is conjunctivitis. Conjunctivitis presents with redness. All of us know that. Yes or no? Yes. Secondly, if it is not conjunctivitis, what other condition can cause redness in conjunctiva? It can be a very simple trivial trauma leading to subconjunctival hemorrhage. A large spot of hemorrhage, a subconjunctival hemorrhage, yes. Then another important diagnosis, if we move again from conjunctiva inside, conjunctiva lines the sclera. So it can be a case of either episcleritis or it may be scleritis. Yes, episcleritis or scleritis, inflammation of episclera and sclera. Then if we see the cornea, can it be a case of keratitis, or if I can say corneal ulcer? So I don't know anything else about the patient right now. I'm just thinking about redness. What all can cause redness in the eye? Yes, I go inside. I say, okay, it can be even a case of anterior uveitis. It can even be a case of angle closure glaucoma. Angle closure glaucoma presents with severe redness in the eye as a symptom, yes. Or it can even be a case of blepharitis, inflammation of the eyelid margin. Blepharitis will not always present with redness of the eye, but yes, when we are forming a list of the differential diagnosis, then yes, it can also be an important cause of a case of redness of the eye. Okay, are we clear about this? Done? Now, based on these differential diagnoses, main differential diagnosis, yes, how do we narrow down? So, what are the questions that you will ask? So, let's say history taking. What are the other relevant questions you are going to ask the patient in a case of redness? History taking in case of a redness. So, the first thing that I will like to ask the patient is, when was the onset? Okay. So, as we already know, onsets we can divide into two types, whether it is acute onset or whether it has been a gradual onset, acute or sudden onset. Okay. If it has been an acute or sudden onset, then it can be two or three things. Primarily, it can be angle closure glaucoma, emergency sudden onset. It can be anterior uveitis. Again, it comes with a sudden onset, or it can be an infective case of conjunctivitis. So let's say bacterial conjunctivitis. Everything else, usually episcleritis, scleritis, blepharitis, this will have gradual. Patient will say started with something, then it developed into something, then it was more, then it was less. So it will have a weaning course, right? Then the second question that we can ask further, moving ahead to the patient to narrow down our diagnosis, is what are the associated symptoms? If the patient says the word itching, then the diagnosis is pretty clear. Then it has to be an allergic phenomena. Yes or no? Right? Similarly, if the patient says that there is pain associated, if there is associated pain, that means it cannot be conjunctivitis. Conjunctivitis very seldom presents with pain. If at all, the patient will say a little bit of heaviness, not pain. Yes. So then we move away. Then we think it may be a keratitis, corneal ulcer presents with pain. It can again be anterior uveitis. It can be angle closure glaucoma. If the patient says, I have blurring of vision, then it can mean only one thing. Blurring of vision will involve cornea. If the cornea is involved, okay, then only you have blurring of vision in case of a redness. Think about it. Conjunctivitis has nothing to do with our visual pathway. Conjunctiva, episcleritis, scleritis, blepharitis, all these will not affect the cornea, and thus they will not cause loss of vision or blurring of vision. But you may be thinking, sir, anterior uveitis also causes blurring of vision. Yes, but anterior uveitis causes blurring of vision again because cornea is involved. So I'm not saying blurring of vision means it will be a case of corneal ulcer only. I'm just saying blurring of vision means that the cornea will be involved. Angle closure glaucoma causes corneal edema. So again, it can be angle closure glaucoma, but it will be angle closure glaucoma causing blurring of vision because it involves the cornea. I hope I'm pretty clear here. Yes. So these are our clues, important clues on how we are narrowing down our diagnosis. Now, one more question which you can ask if it is not a simple, straightforward case, whether your redness has a diurnal variation. Okay, diurnal variation means the patient will say the redness is more in morning, more in night, something like that. If there is diurnal variation present, then more or less we usually find that it is a case of dry eyes. Okay, but if there is no diurnal variation, then usually it is a case of blepharitis. Okay. Again, these are clues. You cannot just say that because the patient does not have diurnal variation, that means it will always be a case of blepharitis. We are using a lot of clues to form our diagnosis. Blepharitis Veins on and off throughout the day. Okay, so the patient will say at some times of the day it is more, at some times of the day it is night, but there is no specific diurnal variation to my redness. Am I making myself very clear here? Yes. Then the last clue, everybody, in history taking is, if the patient is coming to you with redness, then there may be associated discharge. Lot of times patients will say along with redness I have watering or watery discharge, or sometimes the patient may say that we have a discharge which is causing some sticking or stickiness. That means it is a mucopurulent or a purulent discharge. If it is a case of watering, then we either think allergy or we think viral causes. But if it is a case of mucopurulent discharge, we usually think bacterial or chlamydial causes. Right? So this is basically more specific to conjunctivitis. So if you have nothing, let's say a patient has no pain, no blurring of vision, no diurnal variation, the onset is 2-3 days back as it was given to the question, and along with that there is some discharge, then you can narrow down on the type of conjunctivitis based on the discharge. So these are some of the questions which you should be asking the patient, every patient, in case of a redness. This is what I do in my OPD. Patient is coming just saying, sir, I have had red eyes since 3 days. Then what do I do? This is what I do. Yes, I hope we are pretty clear about it. The differential diagnosis, everybody, of redness in the eye, and then how to formulate our questions to get out more from the patient to help us with the diagnosis. All this is before the examination. I have not examined the case as yet. I'm just asking the patient, right? Are we clear? Now, using this information about redness of the eye, we will see some patients now. Okay, so let's see patient number 1. First patient, everybody. Yes, let's read what the first patient is all about. A 32-year-old male again comes to the OPD complaining of redness. This we know, in both eyes since the past 3 days, along with watering and itching. Yes, see how simple does this question become. If you have understood the differential diagnosis of redness, if you have understood the history taking part, then it becomes a single second question. Yes, redness along with watering and itching, and the onset is 3 days. The history is of 3 days. No options, but I hope you already know the answer. Yes, let's see. What is the most likely diagnosis? What is the most likely diagnosis? Watering, itching, along with redness, itching, watering, everything is pointing towards one thing and one thing only. And what is that one thing? Allergic conjunctivitis. Yes, I hope we are clear about this. How simple the cases become. What are the expected clinical findings? Now, what are we saying? We are saying that, okay, you are thinking it is allergic conjunctivitis based on the history of the patient, but now you are going to examine the patient. So when you examine the patient, what are the findings that you will find to confirm your diagnosis essentially? Yes. So what are the expected clinical findings? If it is a case of allergic conjunctivitis, then the first thing that I will see is papilla. Yes or no? Papilla or papillary conjunctivitis. Then what else can I see? I can see a ropey discharge. Ropey discharge is just mucoid discharge. So when the patient tries to wipe away the watering, everybody, he says strings are formed like this. Okay. So certain kind of strings are formed, ropes are formed. And that is why that is called ropey discharge, which in fancy words is called as Maxwell Leon or Lion discharge. Okay. Then if it is a case of contact lens irritation, let's say the patient has not been using contact lenses properly, then you will see giant papillae. That will indicate giant papillary conjunctivitis. The patient, due to constant itching, will have petechial hemorrhages. If it is long standing allergy, then there may even be swollen eyelids. Or if it is an insect bite or if it is something like that which has caused allergy, then there will be some kind of swollen eyelids. So all this together will help us in reaching our diagnosis of allergic conjunctivitis. The treatment of allergic conjunctivitis, I hope, is pretty simple. Everyone knows the treatment will involve antihistamines, mast cell stabilizers, and low dose steroids. Nothing fancy here. All allergies are treated the same way. So first patient, very simple question. I hope everybody understands this. Yes. Now let us move on to the second patient. Again, a 32-year-old male patient comes to the OPD complaining of redness, same line, in both eyes since the past 3 days, along with watering and itching. So till this point, the question is same. It looks like allergic conjunctivitis. But let us see what happens after this. He has been using gentamicin eye drops. So that is the first mistake, yes or no? The patient is telling you the history that I have been using gentamicin eye drops, and you are thinking to yourself, oh, this is a mistake. It is a case of allergy, watering, itching, redness. Yes, it should not have, the patient should not have used gentamicin or antibiotics. But let's see. Why is he using gentamicin eye drops? Because they were bought over the counter. In India, before going to an ophthalmologist, you go to a medical shop. Medical shop people only know one thing. Either they give dexamethasone, prednisolone, steroids, or they will give you some kind of antibiotic. So the over-the-counter drug gentamicin was given. Okay. Now, since using gentamicin, the condition has gotten worse. It has deteriorated, and the eyelids are now erythematous and scaly. Okay. So it was essentially a case of allergic conjunctivitis. Just writing the sequence for you. Then the patient used gentamicin, which he should not have used, but over the counter, and now he is worse. Okay, that is the basic question. So that means, what is the most likely scenario? The most likely scenario in this case is toxic conjunctivitis. Okay, or toxic reaction to the drug. So there are a lot of drugs which cause allergy in the patient's eye. So certain drugs like aminoglycosides, epinephrine, eye drops containing preservatives. Lot of eye drops have preservatives. Uh, that is why we are careful when prescribing eye drops to a patient who we know is allergic to such contents. Then we prescribe preservative free or PF eye drops. Then it can also be due to drugs which have sulfa group in them, sulfa drugs, or due to apraclonidine. Apraclonidine, though it is a very potent anti-glaucoma drug, alpha agonist, but it is very seldom used in the treatment of glaucoma, you would see practically, because it has very, very, very high chances of causing toxicity or allergy on the ocular surface. So any of these drugs, if the patient is using and the patient is allergic to them, then usually you will see that the patient worsens the condition rather than improving the condition. Now, why are the eyelids erythematous and scaly? Because when you put an eye drop, the eye drop usually leaks out from both the sides. Yes, a little bit of eye drop will leak down, and that is making the eyelid also erythematous and scaly. And then you are itching and then you're wiping, so it is making it scaly and it is making it erythematous. So, how do we treat this condition? That is now the next question. We understand the scenario. So, to treat this condition, the first thing is, very simply, the patient is presented to me. I know it's a gentamicin toxicity on the ocular surface. So what will I do? I will stop the offending drug, right? So I will stop the gentamicin eye drop, number one. Number two, what I will ask the patient to do is cool compresses. Allergy gets obliviated, gets calmed down on cold. Yes, so cool compresses to the eye. And then lastly, I will ask the patient a strictly no rubbing. And then for a very temporary period, I will add some kind of anti-allergic, which may be an antihistamine plus mast cell stabilizer. It can be oral or topical depending upon the severity that the patient is suffering from. Okay. So this part, first of all, you need to think, and then you need to start treating it as an allergy. Okay, I hope I'm pretty clear about the case. Yes. So in this case, you would not have found any findings. Yes. And that is why you need to be even aware of the confoundings. Yes. The patient has presented with erythematous eyelids does not mean it is almost always a case of an eyelid infection. It is a stye or it is a blepharitis. It can be something which you are missing in your history. That is why it is always important to ask the patient, if the patient has used any eye drop or any other medication before presenting to you. And you will be amazed, a lot of times a lot of patients have taken OTC, over the counter drugs, and then only when they are not relieved by that, then they come to us trying to save a little bit of money. Yes, we are Indians at last. Okay, moving on to the third patient, everybody. Third patient, a 32-year-old male patient comes to the OPD complaining of redness in both eyes since the past 3 days. Same question, same line till now, everybody. I hope all of us can see. Along with copious dripping discharge. Copious means severe, lot of discharge, and markedly swollen eyelids. So now there is dripping discharge, which is copious, and the eyelids are swollen along with redness. Now, what do you think? If there is discharge, first of all, that is where I think if it is a case of discharge, then again we are talking about some case of conjunctivitis. Okay, but there is no itching. The patient has not said watering, it has said copious dripping discharge. Then I'm thinking more in the line of mucopurulent discharge, MPD. Okay, mucopurulent discharge, conjunctivitis along with swollen eyelids. What is the most probable diagnosis? Anybody can think about this. Most probable diagnosis: severe discharge, swollen eyelids, bacterial or chlamydial. Chlamydial trachoma. Trachoma usually affects the children. Okay, bacterial, anything which is severe, markedly copious. See, these are the words which are trying to guide you towards the diagnosis. The patient is trying to tell you it is a severe condition, markedly copious. These words are trying to tell you the severity of the condition. So if I'm thinking about conjunctivitis which is severe, what am I more likely to answer? I will answer, see, simple words, it's an acute condition, hyperacute conjunctivitis, also known as, anybody remembers, blinorrhea. Okay, hyperacute conjunctivitis, blinorrhea. Yes, with copious discharge, the eyelids are very sticky. With markedly swollen eyelids, the eyelids are again not able to open. So it is almost as if the patient is not able to open the eyes along with the discharge. That is a peculiar photograph which, if we understand, we simply answer hyperacute conjunctivitis or blinorrhea. Okay, now what bacteria causes this? The bacteria which causes this is Neisseria. Yes, I hope all of us remember this, Neisseria. Yes. So point A answered. Now we move on to point B. What other findings can you expect in this patient? Very important. So you have seen discharge. Now you're going to try to examine the eye. When you're examining the eye, what other findings will you expect in this patient? So first of all, if you are able to open the eyelid and see, again, because it is a case of bacterial conjunctivitis, you will see papilla or papillary conjunctivitis. Along with that, you will see marked chemosis. What is chemosis? Chemosis is swelling of the bulbar conjunctiva. Yes, swelling of the bulbar conjunctiva. Then what you will also find in almost all cases of hyperacute conjunctivitis due to Neisseria is pre-auricular lymphadenopathy. Okay, so during your examination, these are the clues you are trying to look at to confirm your diagnosis based on the history of the patient. Am I making myself very clear here? Yes. Now let's move on back to the question. We have answered A, we have answered B. Now let's move on to C. How would you confirm the diagnosis? You have seen the symptoms, you have seen the signs, but now you need to do an investigation to be able to confirm your diagnosis. So how are you going to confirm the diagnosis? So obviously, if you are thinking bacterial conjunctivitis, so what you are trying to do? You are trying to do staining and culture. Yes. So we are sampling the conjunctival discharge, and we are doing gram stain plus we are doing culture. Even though the culture report comes after a long time, it is always better when you have a culture report. Yes, so gram stain per culture. When you do gram stain, 30 minutes you get the report. What are you going to get in gram stain? You are going to get gram Neisseria, gram negative or gram positive, everybody, gram negative diplococci. Yes, so this is what you are going to get. Now, culture, how you are going to do the culture in this patient? Anybody? Culture of Neisseria, gram negative diplococci. So yes, we can do it on blood agar. We can do it on chocolate agar. Or we could do it on Thayer Martin media. Yes. I hope you understand. This is what being a clinician is all about. This is what a clinical scenario is all about. If I am an ophthalmologist and if I am sending a specimen for culture, I need to tell them what culture am I looking at. I need to tell them the probable diagnosis what I'm trying to look at. Yes, I can't just send them a culture and ask or hope them to do every culture on earth. Yes, so this is where we say all your preclinical and paraclinical knowledge comes into effect. I cannot forget my microbiology when I'm doing ophthalmology. Similarly, it is with you. It is 19 subjects, not a single subject. MBBS, right? That's again the key to being a good clinician, to be able to polish and utilize all your knowledge into a single case. Now, we have done this. We are confirmed about the diagnosis. Now, obviously, the next question that you should answer yourself or ask yourself is, how should the patient be treated? Simply, first you have seen, first you have diagnosed, you have confirmed the diagnosis, and now you want to treat the patient. So the treatment of Neisseria, how do you treat Neisseria? That's the question now. Yes or no? Yes. So Neisseria is a severe infection. Even though it is in the eyelids only, we need to treat it systemically also. So the first thing that we will like to do is ceftriaxone 1 gram IM stat. Okay, that's our treatment. Ceftriaxone injection 1 gram IM stat, or very important, if it is very severe, then you can even think about ceftriaxone BD IV 1 gram. Obviously, the dose remains 1 gram. Okay, ceftriaxone 2 times a day IV BT. That is your dose, which is going to be in this case. Along with that, obviously, you need some moxifloxacin eye drop locally. Plus, because there is copious discharge, okay, you need to irrigate or wash, saline wash, at least 4 times a day till you see no discharge. 3 days, 4 days, just keep washing the eye. Do not let the discharge accumulate. And that is how basically you treat this case. I hope we are pretty clear about this. Yes. Now, one more important key that you need to remember when you're teaching a case of Neisseria infection, that along with Neisseria, which infection is very common to occur? Chlamydia. Okay. So along with Neisseria, we see chlamydia infection usually occurs. So when you are seeing a severe case of Neisseria infection, you also give a presumptive treatment for chlamydia. So basically, we are going to give azithromycin 1 gram stat, oral. Obviously, oral azithromycin 1 gram stat. That is what we are going to give in all such cases of hyperacute conjunctivitis. Along with treating Neisseria, we are trying to treat chlamydia also. So this is another important key that you need to remember. Yes. So again, this is all clinical. This is all how to approach a case, how to diagnose, and then how to treat. When I'm teaching you, I can see a patient walking into my OPD. I can see him asking these questions. I can see myself doing that. So that is just that. So when you see a long question with 5 or 6 lines, essentially what I've seen in a case, I'm just writing that in a question and I'm asking you as an MCQ. That's all I'm doing. Yes. Now, let's move on to the fourth patient here, everybody. Fourth patient. Again, you will see a similar case of redness. That's what we are discussing, redness cases. Yes. A 32-year-old male patient comes to the OPD complaining of redness in the left eye. Now see the difference. Till now, patient 1, patient 2, patient 3 was saying both eyes, bilateral disease. But here we are saying unilateral left eye. Okay. Since the past 3 days, and also complaints of pain. Pain, everybody, pain. I hope you remember. We had said pain is associated with. So as soon as the patient is complaining of pain himself or herself, then we know that our differential diagnosis is moving away from conjunctivitis. Yes. So watery discharge and blurry vision. Blurry vision, again, go back to those questions. Cornea is involved somewhere. Okay. He vaguely gives history of having similar episode before also. Okay. Patient admits to being stressful on the job. So there is some stress, and also has a recent history of cold sore. Okay. So now think about this. Slightly more challenging, but easy because you know conjunctivitis is at least ruled out, episcleritis is ruled out, scleritis is ruled out, blepharitis is ruled out, cornea is involved. Because of blurry vision, there is pain. I hope you understand. Okay. Now, along with all this, what is there? Stress on the job, cold sore. As soon as you think of a cold sore, throat infection, throat infections are usually due to viral causes. Yes. That is why in sore throats we say don't give antibiotics, don't prescribe antibiotics, even though a lot of us do if we are already practicing. Yes. But essentially 99% cases of sore throat are not bacterial. They are almost always viral. The common colds that we say, flu, yes, flu, influenza, flu, yes. I hope you understand. So cold sore is making my diagnosis move towards viral. Then two important things: stress on the job, similar episodes previously. So that means this is something which is recurrent probably. That means it can be a virus which becomes dormant, which reactivates. And stress is reactivating it. So I've read a lot about it in medicine, microbiology. Somewhere I am thinking that this is probably moving in the direction of herpes. Herpes will cause what? Herpes will cause keratoconjunctivitis. Yes. Herpetic keratoconjunctivitis, I hope. Yes. So that is where my differential diagnosis is moving towards. Just the history till now. Yes. Now, if it is herpetic keratoconjunctivitis, will it affect one eye? Yes, usually it does, unilateral. Will it cause blurry vision? Yes, because it is kerato, cornea is also involved. And will it cause pain? Obviously, yes. Okay, I hope we are clear. So, which other investigation or test may help to reach the correct diagnosis? So, presumptively, you are thinking herpes. So, presumptively, based on the history, you are thinking herpes, everybody. In the eye, if herpes is causing keratitis or keratoconjunctivitis, what other test would you like to do? Anybody? Anybody? Think about it. Anybody? Very important. Hallmark in all herpetic cases is something very simple, but which all of us do. Anybody? Anybody? I hope a lot of you are answering. Let us see this image. What are we doing, everybody? We are doing the corneal blink reflex. Corneal blink reflex to check the corneal sensations. Why? Why? Because we know herpes simplex causes corneal anesthesia. Hallmark. Hallmark of all cases of herpes is corneal anesthesia. I hope we know how to do this. We take a wisp of cotton. Yes, as you can see, this cotton bud has a long projection. We touch it onto the cornea. When we touch onto the cornea, trigeminal nerve gets activated, goes into the brain. Then facial nerve, the motor nerve comes and blinks, everybody. But if I have corneal anesthesia, no blink. Yes or no? So this is the first thing that comes into my mind whenever I'm thinking about herpes. I check the corneal sensations. Corneal sensations are usually absent or hypoesthesia is there. Yes. How do you compare this? You touch the other eye, you will see instant blinking, and in this eye you are rubbing the cotton, but the patient is not blinking because the patient is not feeling any foreign object onto the cornea. Yes. Am I making myself very clear here? Now, what other thing can you do? What other thing can you do? Anybody? Anybody? Herpes, keratitis. Think about the names. Dendritic ulcer, geographic ulcer. Yes, corneal lesions. So what do you need to do? What do you need to do? Yes, you need to do this. You need to do staining of the cornea. So the second thing we are doing is we are using which dye here, everybody? Fluorescein dye. I hope we've seen this photograph before. Fluorescent dye is an orange colored strip. We are staining the whole surface of the eye. Then we illuminate under cobalt blue light. When we illuminate under cobalt blue light, the fluorescence occurs in green color. Yes. So all this that you can see, this is the fluorescizing fluorescent dye. I hope we are clear about this. Now, what is my diagnosis when I do this? I see a case of dendritic ulcer. As soon as I see a case of dendritic ulcer, I have seen already, what have I seen already, everybody? I have seen coronary anesthesia. I know the patient is having cold sore. The patient has previous episodes, reactivation. I know that the patient has pain, blurring of vision, and redness. I now know that I am talking about a case of herpes keratoconjunctivitis. Okay? Do you understand? Do you understand how to use each question or each information given in the question to arrive at your diagnosis, and then how are you confirming your diagnosis? Now, once you have been able to confirm diagnosis, part A done. What is the most likely diagnosis? Part B, we have already answered this, herpes or herpetic keratoconjunctivitis. What is the best line of treatment? So what is the best line of treatment in every case of herpes, everybody? Herpes treatment, anybody? Herpes treatment, very simple. We are talking about an epithelial lesion. Yes or no? Dendritic ulcer is an epithelial lesion. So what do? We give acyclovir eye ointment 5 times per day for 7 to 10 days. Okay, that's the treatment. Plus, remember always, everybody, what do you remember? That in epithelial lesion, steroids are contraindicated because they do not let the epithelium regenerate, and instead they cause epithelial thinning. If severe or the patient is non-compliant, lot of patients, you will be again amazed when you start doing your practice, if and when you become an ophthalmologist, I hope you do, that a lot of patients do not put this ointment 5 times a day. When they will come to you after 10 days, they will give you excuses. Sir, I go to a job, I can't do it. I have this problem, I can't do it. Sir, 5 times is too much. So a lot of patients are non-compliant. So during your prescription, you have to make the patient understand that this thing can recur. This is dangerous. If herpes becomes dormant, if it keeps on reactivating, your cornea may become scarred. Scarring means you may lose permanent vision. Yes. So you have to make the patient understand that this is about saving your eye, so that the patient is compliant. But still, if you think the patient is non-compliant, if the patient is coming back to you non-compliance, or if it is very severe, then you resort to oral acyclovir. 400 mg 5 times per day for 10 to 14 days. Okay. Are we clear about the dosage here? Yes. That's the treatment. Please remember. Now, let's move on to the last question that was asked to us in this case. Best line of management we have done. What is the best line of management to prevent recurrence? So again and again, I'm telling you that we have to look at this point in the question. Similar episode before. We are thinking about herpes. So when we are thinking about herpes, we know it becomes dormant, it will have recurrence. So a very big challenge in managing herpes keratitis patients is that how to stop the recurrence. So usually what will occur in a lot of patients is you treat the episode. After 6 months, the patient will be back with the same complaints. After 3 months, 6 months, 1 year, the patient keeps on coming back to you. So the patient is also becoming, he's unrestful. Yes, that why is it coming back to me? So very big challenge is to prevent the recurrence, and that is what you need to do. After you have treated one episode, you need to place the patient on prophylactic treatment to reduce the chances of recurrence. Okay. Now, based on the studies that have happened before, we know that if we place the patient on oral acyclovir 400 mg BD for up to 1 year, okay, it reduces the chances of recurrence from around 46% to 13% only. So we know it will majorly affect the chances of recurrence, even though a lot of times we see that even after 1 year of acyclovir, the patient again relapses very soon. We are only reducing the chances of recurrence. I hope you understand. Okay. So you have to counsel the patient again in the way that even though we are doing this, we are just trying to reduce the chances, but the chances are still there. 13 out of every 100 cases will still prolapse, will still recur, and will still keep on having herpes infection again and again. Right, guys? Done. Moving on to the fifth patient in our redness cases, a 62-year-old male patient. So now the age is slightly changed. A 62-year-old male patient comes to the OPD complaining of redness in both eyes. So there is redness again in both eyes and foreign body sensation. Okay. He has crusty eyelids. So this is the case given to you. Redness is there along with foreign body sensation, and he has crusty eyelids. Crusty eyelids means there is some kind of deposit on the eyelids. Why would there be foreign body sensation as soon as I hear this? If there is some kind of deposit on the eyelids that may be falling inside the eye, which is causing irritation to the patient, foreign body sensation to the patient, yes. Now, I'll show you a photograph for this, even though this is not an image based scenario which I am giving you. But because crusty eyelids can be seen without the help of any machinery, you're not going to use a slit lamp. Yes, you can still see just by your naked eye. So let me show you how the patient walked into the OPD. This is how the patient walked into the OPD. I hope all of you can appreciate the crusty eyelids. Yes, all of you can appreciate the crusts formed on the eyelashes or on the eyelids. Yes, are we clear about this? So this is the patient essentially. Now, what is the most likely diagnosis? So as soon as we are talking about the eyelashes or the margin of the eyelid along with redness, there only comes one differential diagnosis into the mind. And what is that differential diagnosis, everybody? What is that, everybody? From the list, blepharitis. Yes. So that means it is essentially a case of blepharitis, very simply affecting the eyelids or eyelashes. Now, what is the most possible etiology? Yes, that is the important question. So now comes theory. How are you using this theory to answer the question etiology? That is what is running into your mind. And based on that etiology, how will you answer question number C and question number D? So let us see what is the etiology. So in etiology, we need to remember that blepharitis, just a little bit of theory for all of you. Blepharitis can be divided into two parts: anterior blepharitis and posterior blepharitis. Posterior blepharitis, for various reasons, a better nomenclature is called as meibomian gland disease. In meibomian gland disease, what is occurring, everybody? In meibomian gland disease, the openings of the meibum glands or the meibomian glands are getting blocked. Okay, so openings are blocked. Okay, and please also remember it is associated very commonly with acne rosacea. Okay, that's your etiology of meibomian gland disease. That's your first part, posterior. Now, anterior. Anterior blepharitis etiologically can be divided into two types: staphylococcal or seborrheic. If it is staphylococcal anterior blepharitis, the name itself is telling you Staphylococcus aureus must be associated with it. In these cases, we see redness, we see crusting of the eyelashes or the eyelids, and we see some scaling. But if we're talking about seborrheic, everybody, we see dandruff-like material at base of eyelashes. So this is what blepharitis in short is etiologically. Okay, anterior or posterior, anterior two types, staphylococcal or seborrheic. Done. Now let's move back. Third question. The third question that we are asking ourselves is, if it is a case of blepharitis, how we are treating that case. Okay, so how are we treating that case? So treatment of blepharitis. Number one, in all of the three cases, whether there is crusting, whether there is dandruff, or whether there is meibomian gland disease, the most important is warm compresses. Okay, so you're taking lukewarm water, you are dipping cotton into it, and then you are compressing, warm compression on the base of your eyelashes. That is the most important. That is going to loosen the crustals, that is going to loosen the dandruff, that is going to give heat and basically open the orifices of the meibomian gland on the eyelid margin. Where does the meibomian gland open? It opens posterior to the eyelashes. So let's say if this is my upper eyelash, this is my lower eyelash, eyelid and eyelash. This is where my meibomian gland opens. Okay, everybody, behind the row of eyelashes in the margin of the eyelid. This will be my eye. I hope you understand the diagram here. Yes, that's it. Okay, done. Now, rough diagram, please. Now, secondly, everybody, if it is specifically seborrheic, I'm writing in short, seborrheic anterior blepharitis, then you need to ask the patient to wash the base of eyelashes with baby shampoo. Wash the base of eyelashes or the base of eyelid, everybody, eyelid margin with baby shampoo. This can also be helpful in staphylococcal anterior blepharitis. Definitely the most important point in seborrheic. It can also be helpful in staphylococcal. Thirdly, everybody, the third thing that you can do is you have to give or you can give chloramphenicol plus steroids eye ointment and then lubricant eye drops, everybody. Obviously, because there is a lot of foreign body sensation in all these three cases, this is what can be done or this is what should be done. This is essentially the treatment for blepharitis, and that's what the case is. Now, moving back to the question again. Very important. You have done A, B, C. If the patient, very important, please see, if the patient does not respond to any treatment, you have done warm compresses, you have been doing them for, let's say, 2 weeks to 4 weeks, you have done lubricants, you have even applied chloramphenicol steroid ointment, but still there is no response to any treatment. What can be the alternate probable diagnosis? This alternate probable diagnosis is a very important diagnosis, but it is very often overlooked. What is that diagnosis? Okay. That diagnosis is this. What is this, everybody? This is Demodex infestation. Yes, Demodex infestation. It is very easy to miss because this is almost looking same as a deposit of a crust or a dandruff. It is very easy to miss unless you are looking in 40x high magnification. So whenever you're seeing a case of blepharitis which is not responding to treatment, you always have to think Demodex. That should be there behind your, diagnosis of blepharitis. That should be there in your mind, that you open a high magnification in your slit lamp and you try to find this. Okay, everybody, Demodex infestation. Because if it is a Demodex infestation, it is continuously going to cause irritation and it is not going to be treated by any of the things we have been doing. Its treatments, even though still not approved, but what has been given to us by various studies is it can be treated by oral ivermectin or by tea tree oil. These are the only two effective treatments. The first thing is because it is an infestation of the hair follicles, Demodex. Okay, you have to remove all the eyelashes, to epilate all the eyelashes. A lot of times we even ask the patients to completely get rid of all hair from the body, because if it is hair, it will be hair, it will be hair in all the hairs. So basically, we are asking the patient to completely get waxed. That is also what we do. Nothing has proven benefits till now, but these are the things you are doing when and if you are able to find out Demodex infestation on the eyelashes. All right, everybody, done. So that's your fifth case of a patient of blepharitis. Now we move on to the next patient. Sixth patient, everybody. We are again discussing everything in redness. That's what you understand, right? That's the beauty. A redness, a simple case of redness, a patient is coming to you with redness, but it can have so many different presentations. Yes, sixth presentation. Again, a 32-year-old female patient comes to the OPD complaining of redness, irritation, and watery discharge. Okay, so we know three words we are getting: redness, irritation, and watery discharge since the past 6 weeks. In all the other questions that we had seen, it was 3 days, 4 days, 5 days. Here we are getting past 6 weeks. Follicular conjunctivitis. Okay, on examination, they have already given you that it is a case of follicular conjunctivitis with pre-auricular lymphadenopathy. Okay, I know the answer. Yes, for me it is pretty clear that so much has been given to you. But how are you going to approach this? So my main key in this question has to be past 6 weeks. That is something which I'm not used to. Usually redness the patient presents instantaneously. Yes. If it has been there for past 6 weeks, then we are essentially talking about chronic redness. If it is greater than 4 weeks, then we are terming it chronic, everybody. So now I need to form a differential diagnosis of chronic cases which can cause redness. The first thing that comes into my mind is inclusion conjunctivitis. Inclusion conjunctivitis, adult inclusion conjunctivitis, which occurs due to chlamydia. The second thing that comes into my mind is toxic conjunctivitis. Like we had discussed in patient number 2, everybody, due to the use of aminoglycoside, sulfa drugs, epinephrine, and so on, right? Then the third thing that comes into my mind is molluscum lesions. And lastly, what I can think of is Perinaud's oculoglandular syndrome. Okay, this is my differential diagnosis. So now when we have a case of 6 weeks, I know my differential diagnosis. So now this basically becomes a case of how to differentiate between these four. Yes. So follicular conjunctivitis is given to me. Follicular conjunctivitis, everybody. Follicular conjunctivitis occurs in case of chlamydia and it occurs in case of viral. Yes. So we know it is a case of conjunctivitis. That means toxic gets ruled out. That means Perinaud's gets ruled out. Toxic we anyways understand. There has to be a history of putting some agent, some eye drop. Yes. Perinaud's oculoglandular syndrome usually is associated with cat scratch disease. No such history given to you, no sign symptom given to you. So that is also ruled out. So we are essentially left with two things: inclusion conjunctivitis, which is due to chlamydia, or mollusk. Mollusk will have presented to you with what, everybody? Umbilicated nodules. Yes. Also, in mollusk, there is no preauricular lymphadenopathy. So, if there is preauricular lymphadenopathy along with follicular conjunctivitis, watery discharge, all this points towards what, everybody? Inclusion conjunctivitis. That means the female patient is suffering from adult inclusion conjunctivitis. That's my diagnosis. Okay, clear about this? Now, which other significant systemic history may the patient report to help with your diagnosis? Very important. So we know it is now a case of suspected chlamydia infection. So if it is a case of suspected chlamydia infection in a female, what other history you may elicit from the patient? What question are you going to ask the patient? What history are you trying to find out from the patient? History taking again is very important. What are you going to ask? You are going to ask about vaginal discharge. Yes, chlamydia, vaginal discharge. I hope it is pretty clear to you in a female. I hope we are clear about this. Along with that, everybody, you will see on examination maybe a pannus. What is pannus, everybody? Superficial vascularization of cornea. Cornea is an avascular structure. Then how can you confirm your diagnosis? You can confirm your diagnosis by GM-SA stain, in which you will find out what, everybody? Inclusion bodies. I hope you remember them. Intracytoplasmic, HP, intracytoplasmic, known as HP bodies. Yes, microbiology again. So that is what you can do to confirm your diagnosis. What is the treatment of chlamydia? We've already discussed previously in the case where we were discussing Neisseria, azithromycin 1 gram oral stat. Yes, that's the treatment. I hope you understand this. Very simple question. The only new thing that you needed to focus on was past 6 weeks. Yes. So in history, please focus on every point. Now, let's move on to the seventh patient, everybody. A 32-year-old woman, okay, comes to the OPD with the findings as seen in the image. So that's a straight image-based question. There is no loss of vision. Very good. That means the cornea is not involved, and no complaints of tenderness. That means there is no pain. So we now know definitely that the cornea is not involved. We need to only focus on the image. So what is seen in the image? In the image, we see temporally there is a nodule which is congested, or I will say redness. Yes, there is no pain, there is no discharge, no history of any discharge, no watering, no pain, no loss of vision. As soon as there is no pain, no loss of vision, I am not thinking uveitis, I am not thinking keratitis, I am not thinking anterior uveitis. There is no mention of eyelashes, I am not thinking blepharitis. There is no discharge, I am not thinking conjunctivitis. So what am I essentially left with? I am essentially left with only two diagnoses. What is the cause? What are the causes? So the causes can be two. It can either be a case of episcleritis, or it can be a case of scleritis. Yes, very simple. So, see again, once I know the differential diagnosis of a case, it is very easy for me to rule out based on the history taking questions or the associated information along with it. Now, how will you confirm the diagnosis? My presumptive diagnosis is episcleritis or scleritis. I need to confirm the diagnosis. This to me looks more like a case of episcleritis. Why? Because it is superficial vessels. See the deeper vessels. These are the deeper vessels. These are not congested. The superficial vessels are congested to me. But let's confirm the diagnosis. How do you confirm the diagnosis of episcleritis? We know something called as blanching. Okay. So let's say this is our patient. Then in this patient, we are using 2.5% phenylephrine eye drops, vasoconstrictor. Phenylephrine is a vasoconstrictor, I hope. Yes, all of us know this. Now, what is happening, everybody? Redness disappears. Blanching of blood vessels. This is seen in episcleritis. Yes or no? If blanching would not have occurred, then it would have been a case of scleritis. Yes. So, blanching, if it is absent, then it is a case of scleritis. That is how you are going to differentiate and confirm your diagnosis. It's pretty clear. I hope there is no confusion in this simple question. Why do we need to differentiate between episcleritis and scleritis? These two words. Why is the differentiation needed? Because we know scleritis is associated with systemic conditions like rheumatoid arthritis, Wegener's granulomatosis, and others. Yes. Whereas episcleritis is usually idiopathic. So because of this, we need to be able to differentiate. Now, once we have been able to find out episcleritis, how do we treat it? The treatment is very simple: NSAID eye drops. Okay. In very resistant cases, you can give oral NSAIDs, but otherwise NSAID eye drops can be given or should be given for the treatment, or some clinicians prefer to give low-dose steroids such as loteparednol also. But why give steroids when the condition can be treated with NSAIDs only? Are we clear about this? Yes, sir. Now, let's move on to the next patient, patient number 8, 8th patient. A 32-year-old man presents with severe redness. Obviously, we know we are discussing redness. What are the associated findings given? Along with photophobia, okay, along with pain, think cornea, and blurring of vision, again think cornea, in the right eye, unilateral, for the past 3 days. Patient had history of similar prior episodes, which were relieved by medication, okay. The cornea has fine keratic precipitates and aqueous cells and flare. Why did we even read the whole question? The last line was sufficient enough to be able to diagnose, yes or no, everybody. So the cornea has fine keratic precipitates, aqueous cell and flare. I've put this case because a lot of times this is what is going to happen in your clinical scenarios. It will be a large clinical scenario, 6-line, 8-line long case. But when you read the last 2 lines, your diagnosis will be confirmed from there only. Yes. So the initial part is building up the suspense, and then the last part is giving out the suspense. And that's what I hope I've been able to make you understand through this. Okay. If it is a long question, always focus on the last 2 lines before reading the full question. Only if the last 2 lines are not able to give you the diagnosis, then move on to the full question. Obviously, we have paucity of time when we are approaching our examinations. So we need to think, how to save time also. So now let us match all the findings in the question, whether our last line is able to confirm our diagnosis. Keratic precipitates with aqueous cell and flare obviously make it a case of what, everybody? Obviously becomes a case of anterior uveitis. Now, If it is a case of anterior uveitis, is anterior uveitis mostly unilateral? Yes. Does it present with redness? Yes. Photophobia? Yes. Pain? Yes. Blurring of vision? Yes. Okay. Similar prior episodes? Yes. Uveitis can recur. Relieved by medication? Yes. So all the case scenario, it is shouting towards the diagnosis of anterior uveitis, also known as iridocyclitis. Okay. Are we clear about this? Now, what is the most probable diagnosis? Answered already. A. Which systemic investigation should be requested for the patient? Very important. Very important. Now comes your knowledge of uveitis. That is where you're using your theory into a clinical case. You know it is a case of anterior uveitis, but what is the word you need to focus on to be able to answer B? Fine keratic precipitates. Yes, I hope you remember quickly. Keratic precipitates can be largely of two types. One is fine and one is mutton fat. They can be third type also, but largely of two types. Fine can be or are due to non-granulomatous uveitis. Mutton fat are due to granulomatous uveitis. So that means we are tackling a case of non-granulomatous uveitis, fine keratic precipitates. Now, what I need to be aware of is, if I'm thinking about non-granulomatous uveitis in an adult, 32-year-old, what is my most important cause of this? So my most important cause of this is HLA-B27 associated conditions, like the most common is, or the most highly associated is, ankylosing spondylitis. Everybody. Then what can be associated? Psoriatic arthritis. And then the last is Ritter's disease or reactive arthritis. Okay. But as a fact, I know ankylosing spondylitis 90% association with HLA-B27. Most important, most common HLA-B27 associated with uveitis will be ankylosing spondylitis. So when I am asked to order systemic investigations, my first systemic investigation will be HLA-B27 screening. Okay. Then, along with that, because I know ankylosing spondylitis causes spinal problems in the lower back, I will order X-ray. Okay. Then, everybody, to rule out, sometimes in initial presentations, even conditions like rheumatoid arthritis can present with fine keratic precipitates, which eventually turn into mutton fat in a day or two. Okay. So, just to rule out, I order what, everybody? RA factor, CRP, ESR. Okay, all the inflammatory markers of granulomatous inflammation, I will also order. Okay, these are the systemic investigations we usually are doing as first line to find out the diagnosis of ankylosing spondylitis related HLA-B27. Obviously, there can be other causes of fine keratic precipitates, non-granulomatous uveitis like Behçet's disease. But then Behçet's disease presents with a whole different proposition systemically. So I am going to look at those signs systemically. Nothing like that mentioned in the question. So based on the question, this is what I'm thinking. Most likely ankylosing spondylitis. This is my primary thinking when I am a clinician. Okay. Now, should a dilated exam be done? See is a very important question. Again, it makes you think like a clinician. That is what you should think about when you are a clinician, when you are thinking about clinical context. Should a dilated examination, that means should you dilate the pupil, be done in this patient? If yes, why? So it is a case of anterior uveitis. Anterior uveitis presents with keratic precipitates, aqueous cell, aqueous flare. Then it can present with pupillary changes like festoon pupil. It can present with what else, everybody? Cyclitic membrane stuff. Yes, we know this. But does it warrant dilated fundus examination? Fundus, anterior uveitis, is not going to go behind the anterior segment of the eye. So does this case, specifically we are talking about this case, iridocyclitis, anterior uveitis, should we do a dilated fundus examination in this? Everybody, yes or no? Very simple. Don't overthink. Yes or no? If you're saying no, you are overthinking. Yes. Ideally, I like to examine the whole eye. Let's just say like that. But even if we are talking specifically about this case, I know something called as panuveitis. I've just looked at the anterior segment, so I've just been able to find out the signs of anterior uveitis. What if it is a case of pan uveitis? I will miss it unless I examine the posterior segment. Yes or no? So, due to the fact that pan uveitis can be there, present with aqueous flare, aqueous cell, or keratic precipitates, in every case of uveitis, it is mandatory that you examine dilated fundus. Okay, so dilated fundus examination should be done because of the probability of pan uveitis also, howsoever little it may be. Okay, done. Now, moving on to the last question, what is the treatment? I hope that is a very simple question. You've been able to confirm it is a case of anterior uveitis, non-granulomatous. So the treatment will be topical prednisolone. Please taper it over a period of 2 weeks or 4 weeks, depending upon the severity. Along with that, you have to give topical homatropine slash cyclopentolate slash atropine, that is mydriatic and cycloplegic, to prevent the formation of posterior synechiae or to break the posterior synechiae if already formed. That's the only treatment which is important for anterior uveitis. I hope we are pretty clear about this, and that's your case finished. Now we move on to the next case, the 9th patient in the series of redness cases. Okay, the last patient, a 48-year-old male. See the image below. Okay, I can see some redness in both the eyes. I'll just circle it. Yes, obviously I can see it. Now, has had irritation in both his eyes along with mild redness since the past 2 weeks. He has used over-the-counter ciprofloxacin eye drop but has no relief. Okay. First of all, he has used OTC ciprofloxacin eye drop. Does it become a case of toxic conjunctivitis like we had seen in patient 2, gentamicin eye drop? Okay. No, it does not. Why? It is just written he has no relief. It is not written that the condition has worsened. It is not written that there is some problem of erythema in the eyelids, some scaling, some whatever, right? So it is not a case of toxic conjunctivitis. Please understand this. Every over-the-counter drug does not mean it will cause toxic. You have to be allergic to it. You have to be hypersensitive to it. Okay? Okay? Right. So now, what is the most probable diagnosis? I am looking at the image. All I am seeing is some kind of superior congestion. That's all I'm seeing. It's not a circumcorneal congestion 360 degrees, it's just superior congestion. That's what I've been shown. Yes. And it is probably touching the limbus or the superior part of cornea also. Okay. And the patient has irritation. What can be the diagnosis? Now, this is some of the rare things. You have seen all the conjunctivitises. They should have discharge. They should have watering. Nothing is there. You have seen episcleritis. You have seen scleritis. Not there. It does not cause irritation. You have seen angle closure glaucoma, different anterior uveitis, keratitis. All those things you have seen. So this makes you think out of the box, out of the normal differential diagnosis that you usually think. Okay. So this, I will say, because it is present superiorly only, is a case of superior limbic keratoconjunctivitis. Superior limbic keratoconjunctivitis. That's my diagnosis. It's a rare condition, but nonetheless, it can be seen a lot of time in your OPDs. Superior limbic keratoconjunctivitis. The only presentation is that the patient has some mild redness, that too limited only to the superior part, touching the limbus, going on to the superior cornea, and the patient complains of some kind of irritation for a long time. In this case, only 2 weeks is there. What is the treatment? It is not associated with any infection, no bacteria. It is not a case of any allergy. The only treatment is lubricants. Idiopathic, that is the etiology. The only treatment is lubricants, eye drops, eye gels. That should be more than enough to treat it. What other conditions can be associated? That is what is important if and when you are able to make a diagnosis of superior limbic keratoconjunctivitis. It is very, very, very commonly associated with thyroid disorders. Okay? thyroid disorders like hypothyroidism, hyperthyroidism. So we almost always see some kind of thyroid disease or some kind of thyroid malfunction presentation associated with superior limbic keratoconjunctivitis. So essentially, when I see a case of SLKC, I am thinking about a systemic condition which I may be able to diagnose based on this. The treatment itself is pretty simple, right, guys? And that's all about our series of case scenario red eyes, where I've discussed 9 different cases with you. Essentially, I've been able to teach you how to approach a case, to approach every case or every clinical scenario. If it is given to you in a question or if you are sitting in an OPD, is to first think about the differential diagnosis. Then you should be aware of the other surrounding factors, and based on that, you're able to narrow down your diagnosis. So this is my clinical vignettes on how to approach a case of redness in the eyes. We'll be discussing some other cases. Moving forward, let's move on to the other case. So now that we are finished with the first case scenario of redness of eyes, let's move on to our second case scenario, discharge in neonate. Though you will find that it is somewhere related to the first case scenario of redness in the eye, let us do this. Okay. A newborn, as seen in the image, as you can see the image, was born at home. Very important clue here, everybody, that the child was or the newborn was born at home and now has puffy eyelids, purulent discharge and conjunctival injection. Puffy eyelids can be seen, purulent discharge can be seen. At the medial canthus, you can see some sticking of the eye or stickiness of the eyes, and conjunctival injection. So now the question is, what is conjunctival injection? Conjunctival injection, congestion, all these mean the same thing. They mean that there is redness of the eye. And hence, as I said, it is somewhere related to the first case scenario of redness of the eye, but still very different because it is a newborn. Why is born at home important? Born at home is important because we know that if the newborn is born at home, there will be asepsis. Yes, so more chances of infection. Now, that is the basic information given to you in the question. Based on that, they are asking you list the likely causes for this condition. So we are basically asking you what are the causes of infection in a newborn which can lead to puffy eyelids, purulent discharge and redness. All are the signs of infection. Okay. So let us see the differential diagnosis, everybody. Okay. So question A, differential diagnosis in a newborn. So first thing that comes into my mind as soon as I hear a newborn having discharge is conjunctivitis. Yes, conjunctivitis in a newborn is known as ophthalmia neonatorum. If the onset of conjunctivitis is within 28 days after birth, we call it ophthalmia neonatorum. Yes, guys, right? Now, secondly, it can be a case of congenital nasolacrimal duct blockage, a very common condition. Yes. Nasolacrimal duct, non-canalization of the nasolacrimal duct, most commonly at the level of valve of Hassner. Valve of Hassner is the valve where NLD opens into the inferior meatus of the nose. Yes. Or it can be a case of dacryocystitis. You can call it an extension of the NLD blockage. If NLD is blocked, due to that there is, infection in the lacrimal sac. Or it can be even a simple case of foreign body. Okay, so if there is a foreign body in the newborn's eye, it can cause irritation, it can cause infection, it can cause inflammation and all those things. I hope we are pretty clear about the diagnosis. If we look at the question, everybody, the child was born at home. So basically, if the child was born at home and after that he has a discharge, puffiness, then the most likely diagnosis we are talking about in the question is ophthalmia neonatorum. Yes, I hope we're pretty clear about this. Now, moving back to the question, question B, second question, everybody. How can you differentiate between various causes of ON or ophthalmia neonatorum? Yes, pretty easy theoretical question. All of us know this table, I hope, by heart, that the onset of ophthalmia neonatorum usually defines the cause. If the onset is within 6 hours, yes, after birth, it is usually a chemical conjunctivitis, which is due to the chemical which is silver nitrate. All of us know this. Then if the onset is within 24 to 48 hours, 1 to 2, then you should be worried. Why should you be worried? Then because it is due to Neisseria gonorrhoeae. Neisseria gonorrhoeae is the most severe cause, most difficulties in terms of treatment, and the presentation will be most severe. If the onset is within 2 to 5 days, then it is due to other bacteria apart from Neisseria gonorrhoeae. 5 to 7 days is herpes simplex virus, and greater than 1 week after 7 days it is due to chlamydia trachomatis. And most commonly we say, if we are seeing a case of ophthalmia neonatorum, usually it will be due to chlamydia trachomatis types D to K. Okay, everybody, This is basically your differentiation. How do you differentiate? The other way you can differentiate is obviously by taking the conjunctival scrapings and then sending them to gram stain, GMSA stain, and culture, as should be done in all cases where microbiology or bacteria or any other microorganisms are involved. Yes, guys, done? Now, moving back. Third question. How could this have been prevented? So basically, we are asking you the profile axis of ophthalmia neonatorum. Yes. So in every case of ophthalmia neonatorum, what is done to prevent it? So what is the profile axis? So profile axis used to be done, historical everybody, by something called as Creed's method. In Creed's method, what did we use everybody? We used silver nitrate. But now that we know that silver nitrate itself can cause chemical conjunctivitis within 6 hours after birth, this is no more used. That's why I say historical. So what is done these days? So what is done is, as soon as the newborn child is born, everybody, eye ointment 0.5% erythromycin is applied into the newborn's both eyes to prevent the chances of ophthalmia neonatorum from developing. All right, everybody. And that's how we prevent ophthalmia neonatorum. All of us know this again. This is a simple theory question, but you just need to be aware of this, right? Now, lastly, question number D. What is the treatment if onset is after 7 days of birth? So basically they are saying that, let's say a child of 10 in 10 days came to you and he has onset. So you're presuming the most common cause chlamydia trachomatis because the onset is after 7 days, presentation is at 10 days. So they're asking you how to treat it. Very important to treat, most common. So how do we treat chlamydia trachomatis? Yes. So the treatment of chlamydia trachomatis ophthalmia neonatorum is, for the neonate or the newborn, we need to give syrup erythromycin 50 mg per kg per day divided in 4 doses, okay, for 2 to 3 weeks. Okay, but what a lot of us miss is that chlamydia or chlamydia trachomatis in this case is a STD. So this ophthalmia neonatorum due to chlamydia will be acquired during delivery from the vagina of the mother. So that means the mother may have been, or the mother is carrying chlamydia in the vaginal tract. So the mother and her sexual partner need also be treated for this. So how do you treat the mother and sexual partner? That is important, and that also needs to be done in every case. So you have to give what everybody? Tablet doxycycline 100 mg BD into 7 days, okay, to both the sexual partner and the mother. The important point is, even if asymptomatic. Even if asymptomatic. So you're not asking the mother about any symptoms, or you're not examining. Even if there is no problem, then also the treatment needs to be done. Okay. Now that we've discussed the treatment of chlamydia trachomatis, I will quickly write the treatment for Neisseria gonorrhoeae ophthalmia neonatorum also. It being the most severe, we should be able to remember. So the treatment here will be intravenous IV ceftriaxone 25 to 50 milligram per kg per day for around 7 days. Okay, that's the treatment if we are talking about Neisseria gonorrhoeae ophthalmia neonatorum. Okay, everybody. So this is the quick lowdown on a case related to redness, case of ophthalmia neonatorum or discharge in the newborn. Now, let us move on to the third case scenario, a case scenario which students usually are afraid of. If such a case is given in the postings, the students usually run hither and thither. Nobody wants to take this case. Yes? Now, the case scenario is diplopia and ptosis. Let's see, everybody. A 15-year-old, okay, the age is given as 15-year-old, presents to the OPD complaining of diplopia, double vision, and difficulty in vision. Obviously, difficulty in vision will be there due to diplopia. Since the past 1 year, on examination, the following findings can be seen. So basically, it's an image-based question. Yes. So let's just see the images on the next page. These are the images. So the image of the child as such is given and the eyes are given. Okay. So first, let us see the image of the child. For a 15-year-old, he's a very tall boy. Yes. Along with that, if we look at the hands and if we focus at the feet, what do we see? We see large extremities. Yes, the hands and the extremities. The hand and the feet are longer than usual. They should be at 15. Remember, 15-year-old. That's the key here. Yes. Now we look at the eyes. This is the right eye, guys. This is the left eye, both the eyes. In the right eye, first, if I focus everybody, I can see the sclera, I can see the cornea in the center, and I can see that the pupil is dilated. Within the dilated pupil, everybody, what do we see? We see that there is a crescent which is formed in the lower part. A crescent in the lower part where there is no lens. That means the lens has moved where, everybody? That the lens has moved up. Yes. So it makes it a case of what, everybody? Superior ectopia lentis, or superior dislocation of lens, everybody. Similarly, if I see the left eye, everybody, sorry, I can again see this complete crescent formed here, everybody. Yes. So again in this eye also, left eye, I can see the same finding, superior ectopia lentis. So now my findings based on the image are tall boy with large extremities and superior ectopia lentis. So based on this, can I answer question number 1? What is the most likely diagnosis? Tall. Tall with superior ectopia lentis should be very easy. Yes, it is very easy. It is a case of Marfan's syndrome. Very easy diagnosis for us. Marfan's syndrome. Secondly, what other ocular findings? So now that you know it is a case of Marfan syndrome, you are looking at other ocular features that can be found. So what are the other ocular features, everybody? The most commonly encountered other ocular features are megalocornea, large cornea, or flat cornea. Flat cornea is called as cornea plana. In a lot of cases, we also find rhegmatogenous retinal detachment. Then we also find dilator pupillae muscle hypoplasia. And lastly, because the eyeball will go long, axial length will increase, these children will present with axial myopia also. Okay, everybody. So these are the other findings apart from the classic supratemporal ectopia lentis. Yes or no? What does it cause? Supratemporal ectopia lentis. Apart from the classic finding that all of us have studied, all of us remember. How do you remember this? Marfan. Yes or no? Fan. Where is a fan located? Superiorly. When it turns, everybody, when it rotates, all the air goes outside temporally. That's how we remember supratemporal ectopia lentis. Very simple key. Yes, done. Now, third question, what is the most likely cause of his condition? That means they're basically asking you what is the most likely cause of Marfan syndrome. So what is the most likely cause of Marfan syndrome? Marfan syndrome is due to mutation of which gene? Marfan syndrome is due to mutation of FBN1 gene. Yes, FBN1 gene encodes the protein fibrillin. What does fibrillin do? Fibrillin provides elasticity to all the microfibrils. The lens, everybody, we remember the lens is held by zonules, microfibrils. So when these microfibrils or zonules are taut, everybody, they are not able to have elasticity, they are not able to move back and forth, they are not able to constrict and relax, everybody. That is when they will break, everybody. Yes, if you are rigid, you will break. Yes, so when they break, it leads to supratemporal ectopia lentis, and that is how this condition is causing supratemporal ectopia lentis, Marfan syndrome. Are we clear about this? Okay, all right. Now, moving on to the last question in this. What can be the other causes of such a diplopia? So, first of all, what I am trying to answer is such a diplopia. What is the examiner trying to tell you by such a diplopia? Such a diplopia. What is diplopia such? Okay, yes. So, if you know, then diplopia is of two types. Otherwise, also I'm telling you now, monoocular diplopia and binocular diplopia. Now, usually students will think monoocular means diplopia in one eye. Binocular means diplopia in both the eyes. But that is absolutely incorrect. Okay. So what is monoocular diplopia and what is binocular diplopia? So let's first see binocular diplopia. Binocular diplopia is if the diplopia disappears after closing each of the eye. Meaning what? Everybody? Meaning, if I have binocular diplopia, When both my eyes are open, that means my binocular vision is there, I will complain of diplopia. But as soon as I close my left eye or I close my right eye, any of the eye, each eye, everybody, yes, my diplopia disappears. So I say I have diplopia only when I have binocular vision. That is why it is called binocular diplopia. Monoocular diplopia is diplopia does not disappear on closing unaffected eye. Meaning what, everybody? Let us understand monoocular diplopia. Let's say I have a case of right eye ectopia lentis. Okay. In right eye, there is ectopia lentis, left eye is normal. So, right now, the patient is complaining of diplopia. Okay. Now, what I do is, everybody, let's say my left eye is now closed. Left eye closed. When my left eye is closed, I am still complaining of diplopia. Why am I still complaining of diplopia? Everybody, because I have right eye ectopia lentis. So why am I having diplopia, everybody? Understand, this is my cornea and this is, in this case, let's say my lens, superiorly dislocated. Yes. So the light ray which is coming into my eye, everybody, let's say the light ray which is coming here is getting refracted first at the cornea by 43 diopter. Then it is getting refracted by lens 16 diopter and 16, and then it is finally forming an image on the retina. But the light ray, everybody, which is going inferiorly, is getting refracted at the cornea by 43 diopter, but it is not getting refracted at the lens 0 diopter, everybody. Yes or no? No power. Okay. That is why it is not making an image on the retina. So there are two different light rays in the same eye. So there is diplopia. Even if I have closed the normal eye, that is the left eye, my right eye, which had the problem, is still open. I still have monoocular diplopia. But if and when, everybody, I will close the right eye. If I close the right eye, only then I will have no diplopia. I hope we are clear about this. Yes. So if I close the unaffected eye, affected eye remains open because the cause is local in only that eye, the diplopia persists. This is monoocular diplopia. Okay, everybody. Now, what are the causes of monoocular diplopia are listed for you? Cataract, ectopia lentis, refractive errors, or spectacle misalignment. A lot of times the spectacle is going up or down, the center is not matching. Corneal opacity is one eye, whichever eye will have the corneal opacity will have monoocular diplopia, or iridectomy or iridotomy. Do you understand iridectomy or iridotomy? I hope yes. If not, then let me again draw a diagram for you. Let's say this is my cornea, this is my iris. Okay, everybody, this is my pupil. Now here I have made an iridectomy. So now what is occurring? Light rays are going inside from the pupil as well as from the iridectomy hole. So again, two images are forming on the retina from the same eye. That is why, if you remember, in cases of glaucoma angle closure, the iridotomy or iridectomy hole is made between 11 o'clock to 1 o'clock because this part gets covered by the upper eyelid. Yes, everybody? Just a clinical correlation to you quickly if you want to understand monoocular diplopia. Yes? Now, moving back, what are the causes of binocular diplopia? Yes. So, binocular diplopia can be due to neurogenic causes. When I say neurogenic causes, I mean to say third nerve, fourth nerve, sixth nerve palsy, which will basically cause squint, if I can say. The second can be myogenic causes. And then the third can be neuromuscular junction causes like myasthenia gravis. Okay. I hope we are clear about this. There is no confusion in this. Myogenic causes can be something like thyroid eye disease. Okay. Clear? I hope we are understanding the difference between monoocular and binocular diplopia. Clear? That's all about our case scenario diplopia and ptosis, question 1 or patient 1. Now, we move on to the second question in, or the second patient in diplopia and ptosis case scenario. Let us see, everybody. A 40-year-old man presents with sudden onset drooping of left eyelid. Sudden onset, basically ptosis. Okay. When he lifts the lid, very important, when he lifts the lid, he notices double vision and hence prefers to close his left eye to be able to see clearly. Okay. There is no other significant medical history. Examination reveals the following. Okay, let us see the image. What does the examination reveal? The examination reveals, let's first see the primary gaze. Primary gaze. In primary gaze, what are we able to see? We are able to see left eye ptosis. Along with that, if you note the position of the eyeball, left eye, down and out eye. Yes, these are the two findings which we are able to see. Now, if we ask the patient to look up, see the patient is looking up and looking up. We see there is elevation absent. Okay. Now, if you look at this image, everybody, image, here the patient is looking towards which side, everybody? Right side. So the left eye has to perform what, everybody? Adduction. Adduction is absent. Okay. We see all this. Now, ptosis. Ptosis means which muscle is gone, everybody? Ptosis means LPS is gone. Elevation absent means both the elevators are gone. What are the elevators? Superior rectus and inferior oblique. Both are gone. Adduction absent means adduction medial rectus is gone. So all this we see is gone. All these are supplied by third cranial nerve, and that is why my most likely diagnosis is third cranial nerve palsy. Okay, everybody? Left eye or left side third cranial nerve palsy. Am I making myself very clear? Now, let us understand, apart from the fact that we've been able to diagnose it, कि when he lifts the lid, only then he notices double vision. But otherwise, he prefers to close his left eye. Why is that so? Everybody, let's understand. It is a case of what? It is a case of third cranial nerve palsy. So it is a case of neurogenic binocular diplopia. See, even without examining the case, based on the history, I could understand it is a case of binocular diplopia. So as soon as he lifts his one eyelid, lifts his left eyelid, the ptotic eyelid, the patient starts having what vision, everybody? Binocular vision. During binocular vision, the patient has diplopia. Okay. But when he closes his left eyelid, then which vision? Monoocular vision. And in monoocular vision, there is no diplopia. Are you getting my point here, everybody? Yes, even though the patient has ptosis, it would have been better that the patient is able to lift up the ptotic eyelid and then see. But because of the problem of binocular diplopia, the patient is actually preferring that the ptotic eyelid remain ptotic. You understand my point here, everybody? Yes. So we need to be able to correct the position of the eyeball in this case so that the diplopia goes away. The diplopia is due to squint. One eye is looking down and out, one eye is looking straight. And that is why the diplopia is there. Binocular diplopia, absolutely different from monoocular. I hope you understand this scenario. Now let us move on to the second question. What is the most important sign that you would check for? In third cranial nerve palsy, you have been able to diagnose, but there is one important sign that you would check for. What sign, everybody? Anybody can think of. Anybody can think of a feature which we need to check. We need to check for pupil. Whether the pupil is spared or whether the pupil is involved. If the pupil is involved, then most likely it is a compressive lesion. Most likely, which compressive lesion? Posterior cerebral artery aneurysm. If the pupil is spared, it is more likely to be an ischemic lesion, everybody, like diabetes mellitus or hypertension. Now, why is that so? That the pupil may be spared or the pupil may be involved in certain cases? Let us look at this diagram. The pupillary fibers in the third cranial nerve, this is your third cranial nerve, run superficially. So these are your pupillary fibers. They run superficially in third nerve. And thus they are supplied by blood vessels which are on the superficial surface. So any compressive lesion will compress these blood vessels and thus the pupil will be involved. But in cases of ischemic lesion, everybody, ischemic lesion, vasa nervorum supply the part of the nerve but not the pupillary fibers, the central nerve fibers. Diabetes, hypertension, all the vascular ischemic lesions, they will affect the deep blood vessels which supply the central part of the third nerve, which does not involve the pupillary nerve fibers. That is why in ischemic lesions, everybody, the pupil is spared. So it is almost important always in every third cranial nerve case to be able to figure out the most likely cause, to be able to see the pupil or examine the pupil. Okay, am I making myself very clear? So if the pupil will be involved, what will occur, everybody? If the pupil is involved, sphincter pupillae muscle, which is supplied by third nerve, will be paralyzed. If sphincter pupillae is paralyzed, the pupil will not be able to constrict. You will find a dilated pupil, mydriasis, dilated pupil. So that is what you need to check for, whether the pupil is normal or whether the pupil is dilated, whether it is involved. I hope we are pretty clear. Okay. Now, B done. Very important clinical question. C. What is the most likely cause? Let us assume, we cannot see in the image here, but let us assume that there is mydriasis in this patient. So if there is mydriasis in this patient, what is the most likely cause? We have already answered this. The most likely cause in this case will be what, everybody? The most likely cause will be posterior cerebral artery aneurysm or any other compressive lesion which is drawing the superficial part of the third nerve and the vessel supplying the superficial part of the third nerve. Okay. Now, let us move on. The next question. If we know it is more likely to be a compressive lesion, PCA aneurysm, what is the urgent management? Urgent management in every case of aneurysm, life-threatening, has to be MRA. Okay, everybody, angiography, MRA, magnetic resonance angiography. That is the most important investigation or the management that you need to do to be able to find out the aneurysm and the location of the aneurysm. Okay, everybody. So I hope you understand this question on ptosis and diplopia and the case presentation here, why the patient is preferring to close the ptotic eyelid rather than open the ptotic eyelid. Okay, everybody. So that's your second patient on diplopia and ptosis. Now we move on to the third patient in diplopia and ptosis. Okay. So the third patient, everybody, a 30-year-old woman presents with drooping of left eyelid. Okay, again ptosis, and has complaints of diplopia. What are the characteristics of the diplopia? It gets worse by evening. Diplopia which gets worse by evening. Okay. She also has been consulting a general physician with complaints of fatigue and exhaustion. So basically the diplopia is getting worse by evening along with fatigue and exhaustion. What can you think of? That the levator palpebrae superioris is also getting fatigued by the evening, and that is why the diplopia is increasing. Okay, everybody. So fatigue as the day progresses is in which condition? What is your most likely diagnosis? There will be ptosis, there will be diplopia. Yes, it will be myasthenia gravis. Okay. Acetylcholine antibodies as the day progresses. I hope you understand. Yes. What other clinical findings can help you confirm the diagnosis? So now once you are presumably saying most likely it is myasthenia gravis, what else are you looking at? So you are looking at the etiology. You know that myasthenia gravis is more common in 20 to 40 years females. Does the profile match? Yes, 30-year-old woman. The profile matches. Then you know that the orbicularis, all the muscles, the orbicularis oculi strength will also be decreased. Okay. So how do you test clinically the strength of orbicularis oculi? What is the function of orbicularis oculi? Blink. So basically to close, yes or no? Yes. So with the patient trying to close with the patient, you ask the patient to close the eye and then you stretch and you are able to absolutely open the eye. See, if I am trying to close my eye, if I open, I will not be able to open. Yes, the patient is closing, but I am not able to open. But in this case, because the orbicular strength is decreased, everybody, examiner is forcefully able to open. This is not a competition where the examiner has to win or the patient has to win. We are just testing something. So please be gentle. Okay. Then we will see that it will not affect, it affects only the extraocular muscle. So the pupil, sphincter pupillae will not be affected, dilator pupillae will not be affected, the pupil will be absolutely normal. Then what else apart from this myasthenia gravis ocular finding can you see which will help you in the diagnosis? A very important sign which you have heard the name of, Kogan lid twitch sign. What is Kogan lid twitch sign? Anybody? Kogan lid twitch sign. Okay. If you're looking down and then you look straight, from down to straight when you look, there is upshoot of the upper eyelid. Okay, everybody. So upshoot of upper eyelid when looking from down gaze to primary gaze. That is what Kogan lid twitch sign is. I hope we are clear about this. What other clinical findings you can see in this patient to be able to confirm your diagnosis of myasthenia gravis. Which test is done to clinch the diagnosis? Very simple. If I suspect myasthenia gravis, I have ptosis. What test will I do? Question has been asked previously also on this in an indirect way. This is just a clinical way. Yes? Yes, everybody? Yes, the test which will be done is tensilon test. So this is my tensilon test, which I can see here. In tensilon test, what we are doing, we are injecting hydrophonium IV, everybody. Yes. And then within 3 minutes, everybody. So this is right eye, ptosis. Before hydrophonium test, after hydrophonium test, 3 minutes, let me write. We see that the ptosis has improved. So very quick test for your diagnosis of myasthenia gravis. Or the other test that you can do on the right side of the screen is called as ice pack test. This is a much more crude test, but nonetheless a very quick test in your OPD which you can do anywhere. Yes. So again, here we see left eye ptosis. Then we see that the patient is holding an ice pack over the left eye. After around 2 minutes, you will see that the ptosis has improved. Okay, everybody. So any of these two tests can be done to clinch the diagnosis. I hope we are pretty clear about this. So what are the tests done, everybody? I'm writing it here for you. Tensilon and ice pack. Apart from this, how can you diagnose this, everybody? To diagnose this, what other things can you see? You can see acetylcholine receptor antibodies will be positive for this patient. Or sometimes we see anti-musk antibodies. These are also positive. Okay. So kinase, okay, musk antibodies, these are also positive in some cases where ACH receptor antibodies may not be present. So these are also two supportive tests. You can say we don't base the diagnosis. We don't normally test for this, but we can test and these will be found to be positive, both of these. So now the last question which remains is what is the management? It is a case of myasthenia gravis. So we are basically asking you the management. You have been able to diagnose, now you need to treat. So obviously the treatment has to be in conjunction with the general physician. But what are your treatment options, everybody? The first is pyridostigmine, even though it is not going to treat myasthenia gravis, but as an anticholinesterase, everybody, the levels of ACH at the nerve endings will remain more and thus the fatigue will not set in. So symptomatically you can treat it. Steroids need to be given, corticosteroids like prednisolone, though you again cannot give it for a long time because they can lead to systemic side effects like muscle thinning and everything. They are given to decrease or reduce the immunity so that the antibodies are not produced. Similarly, immunosuppressants can be given. Plasmapheresis may be done, though not very successfully. Or lastly, in a lot of cases, thymoma may be associated, which is leading to myasthenia gravis. So if that is the case, surgically thymoma can be removed. So thymoma removal or thymus removal can be done for this. So these are your management options, right? Now, Moving on to the next scenario for our diplopia and ptosis cases, everybody. Patient in the image presents with inability to open the left eye. Inability to open the left eye means, again, what everybody? Ptosis. Yes or no? Instead of saying drooping of the left, we are saying inability to open the left eye. That's all. Yes. Now, this is how the patient has come to you. This is how. See the image. Okay. Now, what clinical signs are visible? So, the clinical signs that are visible to me in this image, straight away I'm asking you to describe the image to me, describe the patient to me. So, the first thing that is noticeable to me is this. Yes. Frontalis action, that the patient is coming to you with frontalis action. Why is the patient coming to you with frontalis action? Because we know that if the LPS is not working, frontalis can lift up our upper eyelid. So this is justifying inability to open the left eye, so that the patient is, taught himself or herself to be like this. Okay. Now, what other thing can I see? I can see a little bit of left eye ptosis. Yes, not too much, but if I see a little bit of left eye ptosis, and very importantly, I see left eye upper eyelid crease is absent. See, this is what tells us how good a clinician we are, if we are able to notice this or not. Yes, you can see this fold in the right eye, but there is no fold in the left eye. Okay, upper eyelid crease is absent. Now, as soon as I see upper eyelid crease absent, I see ptosis and I see frontalis action occurring. I know what is my most likely diagnosis. Upper eyelid crease absent gives me the diagnosis as left eye congenital ptosis. Because I hope we remember this skin is lax. So since birth, when we look up, everybody, this skin forms a fold, and through repeated forming of this fold, an upper eyelid crease is present, everybody, as in the right eye. But if the child had congenital ptosis, everybody, then this skin which was loose was never able to fold, because the upper eyelid never went up, and that is why there is upper eyelid crease absent. And that is why the child has taught himself to use the frontalis muscle to lift up the left eye a little, and that is why the ptosis is not very evident, because the child is presenting like this to you. Okay, so a little bit of frontalis is improving the ptosis a little. Okay, I'm clear now. The next question is, what are the other clinical features? So basically they're asking you the other clinical features of congenital ptosis. Yes. So what other things will you expect? The first thing that I will like to examine is called as lid lag. Lid lag means on down gaze, ptotic eyelid does not completely close. So it does not open, it does not close also. Yes, lid lag, that the eyelid lags the movement of the eyelid. When I look down, see, when I look down, my eyelid is completely almost closed. But in this case, the eyelid does not go down also. Okay. What else do we know? We know that there is poor LPS function if we test it. Obviously, that is why ptosis is there. But along with poor LPS function, we also find associated poor SR function. And in a lot of cases, we can even find elevation of chin. Why can we find elevation of chin? If I have a ptotic eyelid, my lower part of the cornea is visualizing everything. So I will do this to look up straight through the lower part of the cornea. So the patient can come up with this posture, head posture also. Though not very common, but yes, it can occur. So these are some of the other findings that I'm trying to focus at finding at, even though my diagnosis is pretty clear based on upper eyelid crease absent. Okay. Now, what is the management? So management may, they're basically asking you what is the management of congenital ptosis. So the first thing in management that I need to do is prevent amblyopia. Which type of amblyopia can occur? Sensory deprivation amblyopia can occur, may occur. What is sensory deprivation amblyopia? One eye has no vision, everybody, or less vision. One eye is completely clear vision because of ptosis, everybody. One eye has less vision, left eye in this case. So sensory deprivation, the light is not going in, so it may land up in amblyopia. After you have been able to prevent amblyopia, obviously the second thing we need to do is surgery. Surgery is usually done after 2 years of age. Usual age is 5 years. Okay. Now, surgery, we have a lot of options. The first is called as Fastenella Servat surgery. I hope you know. Then the second is called as LPS resection. And the third is frontalis sling surgery. Yes, this is theory which I have taught to you many times. Frontalis sling surgery is done if severe ptosis and poor LPS function. LPS is not able to function at all. If it is moderate ptosis, 2 to 4 mm, and fair LPS function, that means LPS is still functional a little bit, then you resect the LPS to make it stronger. Okay, everybody. So these are the treatment options for a case of congenital ptosis. I hope we are pretty clear. Now we move on to the fifth case scenario in a case of diplopia ptosis. The last case scenario, everybody. An 18-month-old baby, as seen in the photograph, presents with the following signs. Let's see the image. What can we see, everybody? Let's focus on the left eye. Let's be quick. Very easy. The first thing that I can see is ptosis. Can I say? The second thing I can see is the left eye looks smaller. Can I say it looks as if it has gone inside? It looks as if enophthalmos. Yes. I even see that the left eye pupil has meiosis. And I also see some kind of hypochromic iris. Not very evident, but yes, if I see this is darker brown, this is lighter brown. It is not going to be absolutely white and black, right? I hope you understand. But I see some kind of hypochromia also. So now I see a lot of MAPLE, hyper high maple. I hope you remember high maple. Out of the high maple, I am able to see E, A, H, H, M, P, and A. So that makes it is a clear case of left eye Horner's syndrome. Instead of just asking you a theoretical question, we have just presented a case to you. The case presents to you, you are examining the case and you are answering the case. But again, it is a probable diagnosis. Yes or no? Yes. If it is a probable diagnosis, the third question is how will you confirm the diagnosis? Clinically, how will you confirm the diagnosis? So to clinically confirm the diagnosis, what do we do, everybody? We use epra clonidine 1% eye drops. Okay. Just going back, this was not the left eye, this was the right eye. Sorry, everybody. Just a brain fade. So right eye, everybody, yes. So we are using epra-clonidine 1% eye drops in the right eye. What will do? The Horner pupil will dilate. The Horner pupil which cannot dilate, which is meos due to dilator pupillary palsy, everybody, will dilate. Why will it dilate? A lot of you must be saying why. Obviously, it is pharmacology, but again, I need to know the pharmacology also. Yes, clinical question. Clinical question. That's what it is. Epra-clonidine acts more on alpha 2 than on alpha 1 normally. That is why, everybody, it causes meiosis by leading to improvement or secretion of norepinephrine. But this is normally. In Horner's, there is no norepinephrine at nerve endings because obviously the sympathetic pathway is lesion. So when there is no norepinephrine, what is occurring is alpha 1 receptor upregulation. And because of alpha 1 receptor upregulation, now the epra-clonidine is acting on alpha 1 and it is leading to mydriasis. As simple as that. Epra-clonidine 1% eye drops. The other test which we could have done was cocaine test, 4%, but cocaine 4% eye drops are not clinically available to us, so that's more theoretical. This is clinical epra-clonidine 1% eye drops to confirm my diagnosis of a case of Horner syndrome. Now, the last question that I'm left is what happens to accommodation in Horner syndrome? Accommodation is increased. Accommodation is a part of near reflex. Near reflex comprises of three parts: accommodation, convergence, and meiosis. And because the pupil remains meosed primarily, and because accommodation involves the processes which are parasympathetic, and because of sympathetic palsy, parasympathetic processes are overactive, ciliary muscle is controlled by third nerve, so we see over accommodation occurring in patients of Horner's syndrome. And that's all about your case scenarios. These are the case scenarios that we have done in diplopia and ptosis, one of Horner syndrome, everybody, one of congenital palsy. The starting was from the case of ectopia lentis, which told us a very important differentiation between monocular and binocular diplopia. And then we understood binocular diplopia through third cranial nerve palsy also. And in between, we had done a question on myasthenia gravis, or a myogenic neuromuscular junction cause of a case of diplopia. Right, guys? I hope you have been able to understand how to assess a case of diplopia. That is how we approach the case. First of all, monocular or binocular, based on the signs around that. And a lot of times, ptosis, as we have seen, is correlated with it, and we are able to clinically assess the case. So these are your 5 case scenarios on diplopia, and that's my clinical vignette session on case scenarios, where I have discussed in detail diplopia, ptosis, and red eye with you, and how to approach such cases. Now, in the second part of our clinical vignette video, I'll be discussing some viva voce questions, not the normal ones you will see, and some new type of multiple choice questions to come.